So, when a person is in crisis, how do we really assess their risk of suicide? For decades, the go-to answer has been a simple label: low, moderate, or high. But what if that entire approach is just flawed? Today, we're going to dive into a pretty fundamental shift in clinical practice, moving away from this impossible game of prediction and toward a much more collaborative, life-saving strategy of prevention. You can just hear the uncertainty in this quote, can't you? It's from a first-year resident, Dr. Lang, trying to assess a patient. He lands on this vague, hesitant label, low, moderate, I guess. And that single moment of doubt, well, it's right at the heart of the huge problem we're exploring today. To really get why this is such a critical issue, we need to look at the case Dr. Lang was dealing with. It's about a 54-year-old man, Mr. Colbin, and his story perfectly illustrates the real-world limits of just slapping a label on a complex human situation. Okay, so you look at Mr. Colbin's case and the risk factors, they're stark. You've got a major life stressor with the affair, chronic pain, daily drinking, those incredibly concerning statements, and he has access to a firearm. When you see all of that, Dr. Lang's low-moderate guess feels like, well, a guess. It's an attempt to simplify a very messy, very dangerous picture into one manageable phrase. And this right here leads us to the crucial question. Is the problem just Dr. Lang's inexperience, or is the entire system of labeling risk low, moderate, high broken from the very start? What if trying to predict such a rare and complex event is just the wrong goal entirely? Well, the evidence is piling up, and it suggests that, yes, it is the wrong goal. Researchers have found that these familiar labels we've all been relying on for so long, they're not just a little imprecise. They have serious, documented flaws that can have life or death consequences. Let's just break this down for a second because this is huge. Poor predictive validity. That means the labels are bad at the one thing they're supposed to do, predict. Poor reliability, that means you could see one doctor and get a low-risk label and see another doctor the same day and get high risk. And poor clinical utility, this might be the biggest problem of all. The label doesn't tell you what to do next. It's basically a dead end. And that's the bottom line, isn't it? Giving something a category feels like you've done the work, but it doesn't give you a roadmap for safety. The whole goal of an assessment shouldn't be to guess an outcome. It should be to create a plan that prevents that outcome. So, this brings us to this really powerful shift that's happening in the field. It's all about changing the fundamental question from how likely is this person to die to something totally different. How can we work together to reduce this person's risk and keep them safe? And this chart just lays it out so clearly. We're moving from an abstract, static label to a contextual, dynamic plan. Instead of trying to be fortune tellers, clinicians are becoming architects, co-designing a structure for safety with the patient. And this new model is built on 4 key components. The first piece of the puzzle is risk status. This gets rid of those vague labels. Instead, it asks, compared to other patients in this specific setting, say this clinic, is this person's risk higher, lower, or about the same? It immediately anchors the whole assessment in a real-world context. Second is risk state. And this is so smart because it acknowledges that risk isn't a fixed thing. It's fluid. Is the patient's risk right now higher or lower than their own personal baseline? Is this the worst they've ever felt, or have they been feeling this way for months? It captures the dynamic nature of a person's struggle. Third, we've got available resources. And I love this part because it's all about action. What strengths does the patient have? Who can they call? What supports can we mobilize right now to help them? It's not just about listing all the bad stuff. It's about building an inventory of assets for the safety plan. And finally, foreseeable changes. This is the forward-looking FERT. It's proactively asking, okay, what could happen in the near future that might make things worse? Because if you can identify those potential triggers, you can build a contingency plan before the crisis even hits. So all that sounds great in theory, but what does it actually look like in practice? Let's go back to Mr. Colbin's case and see how this new model builds a much richer, way more useful picture. We're going to follow a senior doctor, Dr. Santis, as she guides a resident through this new approach. You see what Dr. Santis does? She doesn't ask for a label. She starts by establishing the risk status. Compared to the general population, yeah, Mr. Colbin's risk is higher. But then she gets more specific, asking how it compares to other outpatients or to people who are actually admitted to the hospital. This creates a much more nuanced, relative understanding. Next, they tackle risk state. And Dr. Lang figures out that while Mr. Colbin is definitely worse off than before all this started, his risk hasn't actually spiked recently. Now, that is a critical insight. It tells the team that the situation is chronic, not necessarily acute right this second, which totally changes the kind of intervention you plan. Now look at this. Just compare this detailed formulation to the words low, moderate. It's night and day, right? We have context, we have a timeline, we have a list of actual assets, like his wife and his doctor, and most importantly, we have a specific list of future dangers that we can plan for. And this is where the magic happens. The formulation isn't the end of the road, it's the beginning. Because they identified those foreseeable changes, another crisis with his wife or drinking while suicidal, they can now build a specific collaborative plan for exactly those scenarios. Assessment leads directly to action. You know, when you step back, you realize this isn't just a new technique. It's a completely different philosophy. It's about moving from a passive, kind of judgmental stance to one of active, collaborative partnership, all aimed at building a safer future. So what's the big takeaway here? This new model is a major step forward, for sure. It's more realistic because it focuses on prevention, which we can do, over prediction, which we can't. It's way more useful because it leads directly to an active, shared safety plan. And ultimately, it just transforms the whole conversation and empowers everyone involved to build a path forward together. The old low, moderate, high system, it gives you a blurry, black and white snapshot in time. It's static, and it lacks any real detail. This new prevention model, though, it provides a detailed roadmap, one that you create with the patient, that shows not just where the dangers are, but the safe routes to get around them. And that's really the thought I want to leave you with. This incredible shift from prediction to prevention is so much more than a change in paperwork. It's a change in perspective that reframes the entire clinical encounter from one of judgment to one of partnership, with the shared goal of building a safer future together.